You, a student, تبارك علي مهدي in الزهراء University for Women, College of Health and Medical Techniques, Department of Radiology and Sonar. Today I will present to you a lecture on a child's shoulder dislocation and the subject of radiological physics. Firstly, abstract shoulder dislocation is rarely seen in children. Very few studies in the literature have assessed traumatic glenohumeral joint dislocation in young patients. Introduction. Dislocation of the child's shoulder is the exit of the joint of the bones of the arm from the shoulder socket, and it results in the rupture of the surrounding tissues. And the reasons are the child is carried in the wrong way. The mother may carry him from the shoulder while he is weak at this young age, which leads to rupture of the ligaments. A child violently wearing clothes may lead to the same as the shoulder dislocation in newborns. Is the exit or separation of the ball joint of the arm bone from the shoulder socket and may lead to a straightening of the tissues surrounding it and the connection between the shoulder and the joint, or a rupture occurs according to what the child has been exposed to, which leads to the child feeling pain intense 5 cm above the shoulder to ensure that the oblique rays do not project the shoulder off the edge of the final image. The patient should be asked to rotate their head away from the side under examination to avoid superimposition of the chain over the medial end of the clavicle. Direction and location of X-ray beam. The collimated horizontal beam is directed to the parabol coracoid process of the scapula. Essential image characters. The image should demonstrate the head of the humerus and the proximal end of the humerus, the inferior angle of the scapula, and the wall of the clavicle, including the sternoclavicular joint. The head of the humerus should be seen slightly overlapping the glenoid cavity but separate from the acromion process. Shoulder girdle anterior posterior glenohumeral joint, modified Gracie projection. Position of patient and image receptor. The patient stands with the affected shoulder against the image. Receptor and the torso is rotated approximately 35 to 45 degrees towards the affected side to bring the plan of the glenoid fossa perpendicular to the image receptor. The arm is supinated and slightly abducted. The image receptor is positioned so that its upper border is at least 5 cm above the shoulder to ensure that the oblique rays don't project the shoulder off the edge of final image. The patient should be asked to rotate their head away from the side under examination to avoid superimposition of the chain over the medial end of the clavicle. Direction and location of X-ray beam. The collimated horizontal beam is directed to the parabol coracoid process of the scapula. Essential image characters. The image should demonstrate a clear joint space between the head of the humerus and the glenoid cavity. The image should demonstrate the head, the greater and lesser. tuberosis of the humerus, the lateral aspect of the scapula, and the distal end of the clavicle. Additional considerations. The projection is useful for demonstrating the glenohumeral joint, in-joint instability, and for the narrowing seen in arthritis. Conclusion. Shoulder dislocations are rare and are more rare in children without a fracture. It's easily missed and you need a careful history, physical examination, and correct X-ray view to arrive at a diagnosis. The outcome mainly depends on how quickly the dislocation is recognized and treated. Ethical approval. And finally, thank you for your listen.